So, as mentioned, my name is Mark Arnoldy. I'm the Executive Director of Nyaya Health. And really, my life's mission is to figure out how we can deliver healthcare in some of the world's most impossible places. And I say that because I really shouldn't be here. At about 5 weeks, I had a life-changing skull surgery that prevented me from being socially unacceptable, as the doctor said, for the rest of my life. At age 13, I had a physical chest tube inserted into my lungs to drain fluid from a non-responsive pneumonia that wasn't responding to antibiotics. At age 14, I escaped a scare with lymphoma. And at age 18, I was actually diagnosed with a rare form of arthritis. And if I didn't have great access to healthcare in the US, I couldn't pay for a very expensive injection I take once a week to be able to stand here today. So I don't say this to make this a story of adversity. In fact, quite the opposite. I think my story has been one of great privilege. And the great privilege is that I've learned from a very young age that health is really this fundamental platform of both dignity and of possibility. And so I titled my talk today, Global Health 2.0. I want to try to bring some realism to the challenges we're seeing in global health. And I'm also going to try to make the claim that we're aiming a little too low as organizations. This is about building an effective organization. And so I want to talk about why I feel we're aiming a little too low, what it means to truly put a 2.0 tag on something as big as global health. And I want to do that through the real life story of some of our patients. So I talked about health as a platform of dignity and possibility. And most recently, I certainly haven't come across a patient who is sort of the prototype of dignity and possibility, or as much of a prototype as Priyanka. So Priyanka is now 12 years old. She lives in rural Nepal. And at age 1, she fell into a fire. She fell face forward, she burnt her right hand, and for 11 years, she just couldn't use her right hand. She had a Bergen contracture that was never treated, required surgical treatment. But something innovative happened just in the last year, is that we tried out something new. We tried out a crowdfunding model in global health, and we got her permission. We told her story online, and after waiting around for 11 years, in 3 days, 24 people from around the world funded a portion of her care. Our team navigated that care for her in Nepal, and now she's literally rewriting her future. And she was just part of this photography shoot that we did, and she wanted to tell the world that it no longer hurts to write. But I also tell Priyanka's story because she's the very kind of patient that I think current global health models fail to treat. And so I'm going to tell you why, but I really want you to think deeply about her experience as our customer. Okay, so Priyanka, you know her medical story. To give you some of the social background, she lives in rural Nepal in a region that is 36 hours one way by bus from the capital of Kathmandu. Her family makes under $200 per year. And this is what her actual healthcare journey looks like. Sorry, we skipped one here. So I'm just going to show you, in a very real way, the precise journey for her to get healthcare. So we start out at her home, something very humble, rural Nepal like this, animals on the bottom floor, people on the second floor, some people have a third. Very, very humble, almost no grid power, electricity in these parts of Nepal. She has to walk about 2 hours to get to the nearest, what we would refer to as a clinic or a health post. So this is sort of the primary care base across rural Nepal. This is a new one, and this is the inside. So she's not getting a lot from that clinic, if that's not made obvious from the photos. So if a patient like Priyanka can't get a lot from clinics like this, where does she go? Well, she goes to the nearest district hospital. And that journey looks something like this. Single footpath, suspension bridges, up and down. And in this case, it's quite literally between 4 and 5 hours one way. And if she can do all of that, she can reach a hospital. And this is a real-life photo of the hospital our organization currently manages and operates in partnership with the government. And the truth of the matter is, even for a patient like Priyanka, at a rural hospital, one of the best in the country, she can't get the treatment she needs. And this is why I think we're aiming far too low in global health. She can't get the treatment she needs because it's a surgical treatment. And across most of the rural developing world, you have some very basic surgical care, if any, and often it's very unsafe. So I find this very interesting because I think our greatest challenge in global health isn't necessarily big, huge, single disease elimination programs, which have gotten enormous amount of hype and attention and have been a wonderful thing, and without doubt have saved millions and millions of lives, just verifiable by data. But I think our greatest challenge is to build a comprehensive healthcare system in these places, one that can deliver high quality, low cost healthcare. And so here's what I see happening in the 1.0 world. I see organizations fundamentally set up in 3 ways that aren't serving patients like Priyanka, which, by the way, are numerous, which would have been me if I had been in rural Nepal. There's no national single disease program for people with strange heads or pneumonia or psoriatic arthritis. And so a lot of our patients are sick from things that these huge initiatives in global health that you hear about, they are sick from those things that you're not hearing about. So fundamentally, I think we're still in this sort of 1.0 world in global health. We've set up our structures in 3 ways. We have mission-based models, and basically mission-based models, think of it as a pure charity model, right? They have a very hard time scaling. You can have 1 in 1,000 or 10,000 that are great fundraisers that can really get to scale potentially. But they really usually focus on single shiny sites, and that's the extent of their ability, and it's usually hospital-based care. You have governments, which frankly, a lot of them when left to their own, have a hard time putting together the funding and functionality to really make a system work. So usually when patients like Priyanka knock on doors of governments, they get turned away because there's just not access to what they need. The clinician's not there, the supply chain didn't work, there's no electricity, numerous things break down. And then you have the private sector. And the private sector has some tremendous customer service-oriented healthcare across South Asia, but the poor can't access it. And so the notion here is that it's a very thin infrastructure for people, because when you're talking about reaching the world's poorest, they just can't get there. So we have a different idea about how to do this. Again, the goal in my mind and the biggest challenge is comprehensive, high quality, low cost. So how do you do that? Well, what we're working on, and I admit we're in the very early days, is that we're working on creating a new form of a public-private partnership. And I'm sure that's something that's being thrown around today. But your traditional public-private partnership is often structured such that a government will pay a private company to deliver some kind of service. It works well in some areas, it doesn't work so well in others. And in global health, we've seen it work when you have a big, gigantic teaching hospital that's near a capital city. A government can pay a private company to come in, and they essentially say, if you deliver a certain number of treatments at a certain number of quality, you will profit running this facility. And that's how they're able to attract the healthcare delivery people. But I actually am seeing something different happening in rural healthcare. I think that being a nonprofit and working with the government has an incredible advantage. It has the advantage that we don't have to be concerned with profitability, we only have to be concerned with cost recovery. And so it allows us to take the best of the public sector, the best of the private sector, and push them together. And it allows us to use philanthropy to do what philanthropy was designed to do: take risks, bet on innovation, invest in growth. And so we really think that there's something new happening where we're showing an incredible amount of investment that's growing from the Nepali government. And the governments around the world that are in these type of scenarios are really pretty set up to do 2 things well. That's finance healthcare and provide the infrastructure. But often they fall short in the delivery. And that's where a well-structured nonprofit organization can come in and get paid based on outcomes to deliver great quality healthcare within infrastructure that already exists. Let me say one more thing. And so we've really conceptualized this comprehensive piece as a hub and spoke model, right? That it can't just be a hospital, it can't just be community health workers, it can't just be a maternal health initiative at clinics, that you actually have to package this together. And so it's a district healthcare unit, right? It's a central hub hospital connected with a network of clinics, and community health workers move between the tiers, ensuring that every patient gets followed up and they get referred when they need to be referred as well. But even in that scenario, patients like Priyanka don't get treatment. Which is why we created a crowdfunding model, because referral care doesn't really exist in the developing world. Dr. Paul Farmer, one of our advisors, said that referral care is a social fiction, and he is very true. Many people think if you have good hospital A and good hospital B, you just send the patient and everything works. That is not the case in global health, and what crowdfunding has enabled us to do is really open that up to create a national referral network. So when all of a sudden we told individual stories online that were fully accountable, fully transparent, the people who were operating on our patients at partner hospitals knew they couldn't mess up, or they knew they couldn't lie about the price, or they knew they couldn't lie about the follow-through, because there's a globe of people, the crowd, watching and creating expectations around this person's care. So we've launched this crowdfunding model, and just over the last year, we've formed about 9 country-level hospital partnerships, and we've created the first national referral network in the country of Nepal through the extent of something like crowdfunding. So I just want to wrap by telling you sort of what we've done and where we're headed. We view ourselves in research and development phase. This grand hypothesis or this big idea about this new form of public-private partnership has some proof. It doesn't have everything we need, but we're heading in the right direction. So over the last 5 years, we've built up and are currently operating at 1 hospital, 6 clinics with 100 plus community health workers. And during that time, we've treated 150,000 patients at about $12 per capita. The current average in the country of Nepal without any additional support is $5 per capita, coming direct from the government. We currently employ 160 Nepalis, and we've catalyzed $140,000 of investment, direct cash investment from the Nepali government in addition to their infrastructure during that time. And actually 2 days ago, we just doubled that in addition to getting all of the medicines provided for free through the public supply chain. But here's where we're going. We're trying to replicate this. So still working at the 1 hospital hub that's treating about 50 to 70,000 patients a year, growing to 38 clinics, 400 plus community health workers, and sprinting towards hitting this price point where 40% of our patients, or 40% of our funding can come from the government. And if we can keep it under $20 per capita, we have one of the best business and investment cases in global health to make to that government. So this is what we're doing. In 3 years from now, we'll be at about 200,000 patients per year. So I want to close, a little bit of promo, I admit, but now that you know Priyanka's story, you may see her on the New York City subways or other places coming near you. We are fortunate to come into an advertising award to try to spread this new model of crowdfunding, because we think it's far more about than just this individual connection. It's actually doing things like creating this national referral network. So for the month of December, you can log on to crowdfundhealth.org and see the types of patient stories and actually invest directly in a share of any patient's treatment or safe birth for as little as $10. So with that, I'm going to wrap, and I would invite you to contact me directly if you have any questions, and we'll be up here for the panel as well. But please feel free to reach out, and thank you for your time.